Telford. Good afternoon, everybody. Welcome to this meeting of the Shropshire, Telford and Wrekin Integrated Care Board. Good to see you all. Nice to be here in the Guildhall, and thanks to our colleagues from Shropshire County Council for hosting us this afternoon. We're very grateful. When it said the council chamber, I was expecting something like I was in Staffordshire earlier in the week. This is much more salubrious, I think, in terms of a practical space. So thank you very much for hosting us today. We appreciate it. Tanya, welcome. I think this is your first meeting of the ICB. You're very welcome as interim chief executive of the local authority. And Phil, I believe this is your first meeting as well as interim chief delivery officer. Until Monday, when you have another role. Yes. All right. Can I ask people if they are going to speak? Got colleagues joining us remotely. People will need to turn their mics on. It's clicking the right-hand button on your console. If you don't do that, then people won't be able to hear on the Teams call. And if you've finished speaking, please then turn your microphone off. That'd be appreciated. The meeting's been recorded and will be available on our website after the meeting. I understand there's no fire alarm test scheduled today. Great, so we've had a number of apologies for absence today, none from board members, but in terms of from board participants, Jacqueline Small, Ned Hobbs, Felicity Mercer, Tracy Shrewin, Rachel Robinson, Helen Onions, Jackie Jeffrey and John Brewer. Are there any other apologies that anyone needs to give? Yes.
I'm not sure if you said Councillor Kelly Middleton.
I didn't know. Thank you very much.
And Vanessa one.
Vanessa's attending a course at the King's Fund today. Great, thank you very much. Moving on then to declarations of interest. Are there any declarations of interest that anyone needs to make, either in addition to the declarations already on the agenda, or any in particular that people wish to stress in items relating to the agenda today? No, great, thank you very much. Moving on then to minutes of the previous meeting. Meeting was held on the 25th of September. Can I first of all seek consent to approve these as a correct record of our proceedings? Any issues in terms of accuracy? Therefore, we will agree there's a correct record. Alison, matters for action. I think most of those have been covered.
Yes.
Any particular actions that haven't been adequately dealt with in the actions log, or any new actions we haven't picked up on? Great, thank you very much. Then we move on then to questions from members of the public. We have one question. Our policy is that question will be dealt with outside of the meeting and will be reported as part of on our website in terms of transparency. But that question will be answered outside of the meeting. Okay, moving on to item 233, which is a residents' experience. Delighted that we've got Sherilyn joining us today. I know she's going to come and speak to us shortly, but Lorna, do you want to give us a little bit of context?
Yes, so welcome to Sherilyn Ndlovu, who's the EDI midwife staff. She is going to come and talk to us about some of the work that she's been doing around improving equality, diversity and inclusion and access to equitable care. And I'm sure she won't blow her own trumpet, but she received an award for the BAME Midwife of the Year nationally this year. So congratulations on that. We're really looking forward to hearing about the work that you did that led to that really prestigious national award.
Thank you so much for the great introduction, and it's an honour to be here and speak with you all. So I've been in post now for almost 11 months, and during that time it was really important to embed the patient voice and our service users and the communities that we serve within our day-to-day workings. So the most important thing for me was around engagement and making sure that we engage with not only seldom heard communities, but communities that previously may have not had a consistent relationship with ourselves. So it was reaching out with communities such as our Muslim families. So we were able to set up a Muslim mum and baby group, which consistently runs every Wednesday during term times, and that's supported by local organisations in terms of education, training, that preconception health, as well as maternity bespoke education. We have an Afro-Caribbean mum and baby group that we started through communication with the Nigerian, Ghanaian and Afro-Caribbean Telford Association, as well as our Eastern European families via the Shop Euro, supporting them in gaining funding, if it was a funding needed, a building to work out of, but also just also linking in with some of the pre-existing organisations, for example, with our home starter groups, to make sure that everybody felt heard. Alongside the Shrewsbury and Telford engagement team, we looked through making sure that families were heard that maybe didn't have access in terms of digital exclusion. So that was around making great connections and sustained with our Gypsy Roma traveller community. So every 3 months, as part of an MDT, we attend some of the sites, and it's about addressing health needs, questions, if there's any barriers to access to health, how do we kind of manage those, but also how do we make sure that we are as patient friendly as possible, really. And then the other side of it was around governance and making engagement with families, as well as addressing those inequalities, reporting through data day to day. So now in all our governance reportings, we include EDI aspects to everything that we do. And lastly, within that work was around educating our workforce. So I wrote a book for Cultural Insights, and that covers over 27 languages and traditions from around the world regarding maternity and birthing traditions, really, because we'll all come across different nationalities, different religions, different cultures, but actually it's putting that into one place where it's accessible for everybody. So that's something that's free, and staff have access to physical copies and digitally, as well as an education package which is delivered as mandatory training for maternity workforce and neonates starting from next year.
Wow.
Brief, thank you.
Can I ask, and first of all, thank you very much for that. And it's really clear to see your passion. What inspires you and motivates you to do the work that you do?
So I come from Wigan, if anybody knows where that is, born and bred. So growing up there, both my parents work as social workers. So from a very young age, just an understanding of the world around you and actually the challenges and the differences. And actually what brings us together has always been a passion of mine. So everywhere I've always gone, it's about making sure that everybody has a fair chance. and I believe that we should all be equipped to do so.
Sharon, there may be some questions that colleagues might have. You okay with that?
Yes, definitely.
Any questions or comments or observations from anyone? Simon. Sorry, Tanya.
Thank you so much. What a wonderful way to begin our ICB with such a passionate introduction to the work that you've been doing. I guess I'm a social worker, so it's great to hear that your parents were social workers and that helped you in your journey to your career. What is a key learning that we can take forward, do you think, as an ICB in terms of how we work with individuals differently, as you've kind of experienced?
I think the main theme has been around any of our engagement initiatives being sustained so it doesn't feel tokenistic. And I think maybe previously where we've engaged for need of maybe a survey, etc., but actually if groups, communities, families understand that it's reciprocal, so we have so much to learn from them and vice versa, that makes for a really great relationship, really.
Sam.
So, look, as others have said, firstly, congratulations on the award. I love how when you're presenting and that energy enthusiasm, you just drop in, oh, and I've written a book. As though like that's just the normal thing in terms of that we've all done, haven't we, whilst we've been carrying on delivering our jobs. So then looking forward, I guess what next? And if you were to say to us as a board, could you make sure you've got a real focus on over this coming 12 months? What would you say to us? So what next for you in terms of the work that you're doing, but also for us as a board, what would you say to us in terms of make sure we've got a real view and a sight of over the next 12 months?
I think in terms of maternity, next is trying to think about working out of the neighbourhood work, and obviously as it's kind of where we're heading to. So it's enabling maternity services as much as possible to get back out into the community really, and my main focus is on trying to facilitate that and make sure that even in the initial stages we are targeting areas and families where we're unique in that there's rurality in kind of our demographics, but we're actually addressing the places that need that the most. So from an ICB perspective, I would just ask for as much support as possible in getting us back out there with our families.
That's good. Deborah and then Joe.
Thanks, and I echo the enthusiasm that you expressed there. We heard in our last meeting from the representatives in the community in Quay Arms, and that was more about the work that we've done around menopause. But in working for that community, they also spoke a lot about antenatal and postnatal care. It's a community where lots of people come from another country and are very unfamiliar with how we set up services here. And so I'm thrilled to hear about them as a mother and baby group, because that was specifically one of the things the community had asked for. And I think it is so important to actually ask the community what they want prior to that piece of work. When I spoke to maternity colleagues, I think it's probably before you were there, and they said, "Oh yes, we're aware of that community, and we've made adjustments for them, but unfortunately the adjustments they made hadn't helped the community, they hadn't met the needs, and actually in going to talk to them, they could then tell us what would be useful." So, and this kind of completes that loop, because it sounds as if you've heard that and put those things in place. So well done, thank you so much.
Thank you, Joe.
So Jo Williams, Group Chief Exec at Southend Shropcom. It's just a comment. Just we are so proud of you and the work that you've done, and we take every opportunity to say thank you. But if we could bottle your enthusiasm, but just thank you, because how you find the energy and time to do what you do. And it's great you're here today. So thanks for all you contribute.
For your support, Jo. Thank you.
Sharon, so thank you very much for joining us today and for sparing the time in a busy schedule to come and talk to us and share your thoughts and experiences. And again, just want to echo what others have said, to congratulate you and thank you for the work that you're doing. Carry on, and we would love to hear more about your experiences in the future. So thank you for your time today. Much appreciated.
Thank you.
It's always good, isn't it, to have at the start of our meetings a bit of framing around either the customer, the patient, or the staff member. I think it's really important that we use that as an opportunity to then move on to the rest of our agenda. We've got a nice one EDI later on, and there'll be a good opportunity further to reflect about the work that we're doing around tackling inequalities and discrimination and other forms of inequality. And I think it's very helpful that we have the context from the presentation today leading us into that discussion. Thank you again, and Jo, you must be very proud. Yeah. Let's move on then to the other items on the agenda. And I think next is my report. Hopefully this is self-explanatory. I'm not proposing to go through it in any detail apart from two issues I just want to highlight. One relating to also to equalities, diversity and inclusion. And that's the message that's coming out from NHS England around tackling anti-Semitism, and really important in the current context, the current environment that we are thinking through collectively. What does that mean, and how do people of the Jewish faith feel that they are being treated when they're accessing public services, and just check in with that. And similarly, just to also note to report Simon's appointment as the Cluster Chief Executive. I know that some of us were aware of that at our last meeting, but it hadn't formally gone through the approval processes. And that's all I would wish to say in relation to my report today. Happy to answer any questions. Simon, your report.
Thank you, Chair. And again, we'll assume and take the paper as read, a couple of bits just to highlight and pull out. I mean, I think we will come back to future board meetings with the progress in terms of diabetes, both to build on the work that's taken place, but recognising the clear clinical priority across our system in terms of the scale of improvement that we're striving for around that. Colleagues who have been on this board for a while will remember some of the challenges we face in terms of the EPRR, so our ability to respond to emergency preparedness, resilience and our response. We get assessed on that on an annual basis by NHS England, and clearly what is more important probably than the assessment is our ability to respond and make sure that we can discharge our responsibilities as a category 1 responder. But positively, as you can see, we've made progress on a year-on-year basis, and equally our provider colleagues have demonstrated that improvement as well. So the report highlights that and shows the progress that we have made in that space. There's an update in terms of the National Neighbourhood Programme, given the focus in the 10-year plan and the work that we'll continue to develop in terms of the placed agenda, then being part of that is important. I reference and want to thank colleagues in our prescription ordering direct service, recognising that we're decommissioning and closing that service down, but do want to recognise and just highlight to the board the staff that have worked in that service. The relationship that they build up both with patients and with general practice has been very impressive, and the leadership that then those staff have continued to demonstrate as they work through a challenging time in that space. Clearly, as we shift to becoming a strategic commissioner, and we're much clearer in terms of what our responsibilities are, and we're looking at the developments that are taking place with the NHS app and with general practice services, there is a need to make sure that we're working through that sensitively, but equally making decisions that move us forward as an organisation. And so that decision's based on the evidence base that was available in that point. I talk about some of the work that's taking place from a digital perspective. The board does need to, there's an ask in terms of 2 decisions around changes to the proposed amendments to the Constitution and amendments in terms of the REMCOM. So would ask we come back to those to make decisions on that. But the final piece is just to recognise that we have been confirmed now as, from an ICB perspective, received formal notification to exit the recovery support programme. Colleagues will be aware that's the highest level of NHS England oversight. So earlier this year we were able to discharge our legal directions and undertakings, which was very positive. And now the ICB has been able to demonstrate sustained improvement, and that's been recognised nationally, and we've been unable to, it's been agreed to remove us from that recovery support programme. As we mentioned at the last board, I just want to continue to reiterate and be really clear, that's a really positive step for us as a system. but it's a step. It's not the end point, and it's a step because our focus remains on supporting staff and colleagues to make sure that staff follows very closely behind in that space, so that as a system with our providers, we will all then have stepped out of that recovery support programme and stepped out of that highest level of oversight. And the important piece behind all of that is that that's driven by the way we deliver services and the outcomes for local people. So this is not a means to an end, as in we must tick the boxes and achieve and jump over the hurdle. This is about demonstrating the genuine improvements in terms of patient care and the impact on residents, and that then being able to be demonstrated and recognised. So we need to just recognise the importance of that, but see that as a step forward on that basis. Happy to take questions or comments, Chair.
Thanks, Simon. Just to touch on the last point you made in relation to obviously the importance of removal from the RSP programme, but also the continued improvements that collectively we need to make, and doing that in the context of all system colleagues no longer being under the highest level of scrutiny. But at the same time, just thinking about this from a population lens, that our collective desire is to make sure that we're providing the best possible healthcare to the population of Shropshire, Telford and Wrekin, and having that laser-like focus in terms of what we need to continue to do to deliver that is going to be really important as we move forward. But I think it's just important as we the ICB is removed from RSB, just to acknowledge a huge amount of work has taken place and to get to that position from a range of staff right across the ICB and the system. So it's important that's recorded in our minutes, I think. Any question for Simon before we move on to the recommendations, particularly relating to the Constitution and the audit?
On screen.
Sorry, Pauline. Apologies, Pauline.
That's all right, Chair. Thank you very much. It was actually in relation to your report, so we moved on quickly to Simon. So first of all,
we can't hear you. Hold on a moment. So let's see if we can try and resolve the technology.
We could hear you. We could hear Pauline really well online.
Yeah, they can't hear me.
Can you guys hear me?
Okay, it's being looked at urgently. We'll try and make sure we can resolve this imminently, and as soon as we can, clearly you can hear me. As soon as we're in a position to resolve that, I'll bring people back into the conversation. So apologies for that. Any other questions for Simon on his report?
Pauline, you can put it in chat.
Actually, Pauline, once we've resolved the technological issue, there's a couple of approvals we need to make. One is in relation to a proposed amendment to the Constitution, a minor amendment, which is in relation to the chair in particular remuneration. And the second point is in relation to proposed changes to the Remuneration Committee's terms of reference. Be happy to approve those changes. Yeah. Thank you very much. I'm looking to see about whether we've got the technology fixed. Okay, I'm keeping rolling. Okay, remind me to come back to that point later on. All right, let's note the Chief Executive's report then with those changes to the terms of reference in the Constitution. Moving on now then to the risk management report. So this is an item for assurance, Alison.
Yes, thanks, Chair. So I won't go through the report in any detail. What we've done is we've pulled out changes that have been made to both the Board Assurance Framework and the strategic risk registers for the ICB and the system. They've been annotated so that you can see them in detail. I'm happy to take any questions. I'm sure other exec colleagues will be able to answer in more detail on some of the risks that they own.
Can you say a bit about the sort of the proposed alignment with the risk processes both within Shropshire, Telford and Wrekin and Staffordshire and Stoke-on-Trent as we seek to trust them, and how's that going in terms of that initial assessment of a shared understanding of risk?
Yeah, so the board will remember that we've had a couple of discussions in board development sessions about refreshing the current board assurance framework and our risk registers, which is currently in train at the moment. We've had some tentative discussions in the two governance teams between how we then moving forward in a clustering model, how we can bring together risk management approaches so that we've got a similar approach for the staff that will be working in the one structure. That's only just started, but what we plan to do is look to align the policies so that we've got the same way of working. We'll need to do some training with staff at a later date, but I'm happy to bring back a further update, maybe through the transition committee, if that would be helpful.
Particularly around the point you flagged in the report around risk appetite as well, that I think we're all sitting with a lot more risk currently, and therefore our risk appetite is likely to need to shift, but we need to do that consciously rather than it just happens to us.
Yeah.
So I think it's about making sure that we're creating space and time, either in the transition committee or collectively across the ICB cluster, just to consider those risks that are common and distinct and different based upon our BAF, but also to have a conversation about risk appetite as well. Trevor.
Get the instructions at the beginning, sorry. Just a pedantic point to that, we've got a number of risks where we haven't got owners and completion dates. And clearly when we've got a paper that is showing a red and we're not sure who's supposed to correct that. So could we have that updated as quickly as possible?
Yes, let's make sure that's updated. Any other comments or questions in relation to the risk report? No, can we receive the report? Thank you. Pauline, I think we might be able to hear you now if you would like to try and raise the point you had on the Chief Exec's report.
Okay, can you hear me?
Yes, we can. Yes.
Excellent. So it was on your own report, Ian, if that's okay. So firstly, Simon, congratulations on your appointment. And my question was under 2.2. What health and wellbeing support has been put in place for the staff that are being affected with the changes that are happening through the transition?
So Pauline, a really important question, actually. There's a range of support that's been put in place that varies from individual external offers, the individual internal conversations, and the support network. So the NHS England at a regional level have provided access to support. We've also opened out the staff wellbeing support offer from SSOT colleagues to be across the cluster in its entirety, with really clear signposting in terms of that. And there is a process that's also in place now in terms of the future roles and future job and the support around that, where the recruitment team and the workforce team in SSOT is also now operating across the cluster footprint for both ICBs. So there is the combination of that development support, the individual support and ongoing conversations, as well as the more formal piece that we're putting in place around agreeing what the portfolios and the ongoing work and the focus looks like. So there is all of that, but then the most important piece is the commitment to an ongoing dialogue, Pauline, to say if somebody comes and says, I really need some help with, our commitment to try and do our very best to make sure that we work with individuals to meet their support needs as best as possible. So core standard offer, equally the ability to have an individual dialogue and the support around that as we take that forward.
Helps to give the
Thanks.
board,
Thank you, Simon.
to give the board a bit more assurance that we had a joint transition committee yesterday of the two ICBs, and it was a major item of conversation around the not only the approving and understanding the process and some of the timelines within that process, but also in terms of making sure that we were getting assurance around the support that was being provided to colleagues. And Simon has reiterated that today, and it's something that as board members we would continue to make sure that we are assured on. Thank you for raising that. It's really important.
Thank you.
Okay, let's go then back to then the agenda and the short and medium term planning paper. I think that's you, Claire.
It is, thank you. So planning for the system is an all year round process. It's certainly not something that we just pick up once the guidance lands, but I think it's fair to say that we're definitely in the thick of the busiest part of that annual cycle. We are now in receipt of some of the key guidance that we need to enable us to draft our plans in response to the asks that have come down from the department. The paper here provides a summary. I know it's quite lengthy, but it is a summary of the guidance that we've had so far. And since we wrote this paper, we have now received indication of allocations for both revenue and capital. So as you can imagine, there's a lot of work happening at the moment. We committed as a system to a system first approach. That's hugely helpful in the work that we're doing, and albeit we have individual targets now to achieve, which is part of some of the changes to our process, the fact that we're working collectively on our planning really does bear dividends, because when we come to triangulate plans, we're confident that we will be telling the same story in terms of the ambitions that we've got for performance, workforce and finance. We were able to share some very early headlines with the System Finance Committee yesterday as we work through our first cut of our plans, and that's in readiness for a draft submission, an initial submission to NHS England this side of Christmas. The one thing that I just wanted to flag to board is that board assurance remains even more critical than ever. So from an NHS England perspective, they want to be absolutely certain that our boards, both individually and collectively, are committed to delivering the plans that we submit. So one of the things that our partners are doing at the moment is to be working through individually with their boards what their plans look like, but at system board we will look at all of that in the round to make sure that we're content that what we're describing delivers our commissioning intentions, our strategic intentions. I think it's really important that when we convene to have a look at these and to sign off the statements we've been asked to sign, we need to bear two things in mind. One is to have a look at what we're returning. Are we content with the story that we're telling with the information that we've got at that point in time? But also we will need to consider what else needs to be done before we submit any final plans in kind of February time. Some of the guidance has landed quite late, so there's a lot still to be done to work through us really optimising the resources that we've been given for the future years and how we want to deploy them. So happy to pick up any questions. I wasn't going to get into any of the detail today. This was more about what's coming and where we need your help over the next month or so.
Claire, do you think currently that we have a good understanding of the process and making sure we've got the governance choreography aligned to make sure not only are we in a position for providers to sign off their elements of the plan, but also to collectively have that view, acknowledging that we don't have maybe there's still a bit more guidance to come, and also the timescales are extremely tight. It gives some assurance to me that the governance around this is going to be as robust as it can be.
Yeah. So the system planning group are working together at the moment just to make sure that the calendars and diaries align. We're yet to put in an extraordinary system board, but that's work in progress in the background at the moment, because what we wanted to do was make sure we didn't hold that too early. We want our provider boards to have been able to meet and sign off their elements before we come together, so that will be coming. But we're doing as much as we can. Obviously, this will be a first submission, so the key thing is to know exactly what there's still to do.
So I think, I think Claire set out, and the slides jointly produced across the cluster are helpful in terms of just setting out what the expectations are. I think our challenge as a board is to make sure that we create the time to maximise on the opportunity around setting this as a 3-year plan, because I think we are good at doing that. How do we deliver our 12-month operational plan? I think it's making sure that we've got the time, both collectively and then with organisations, to really then think about, with provider organisations and partners, to really think about actually what does our sustainable health and care system look like in 3 years, and how do we make sure we've got the right narrative around that. Now, I think we've done a lot of that work previously, but given then we've had the 10-year plan published, we've got model ICB blueprints and other bits that have been published, I just think that refresh of that and having the time for us to really think about what's our ambition for our population and for our services is making sure that we capture that, because I'm confident that the governance bit will meet all the timetables, but it's making sure we've got the thinking time and we don't just meet all the timetables.
That's really helpful. Andrew.
Yeah, I think it picks up Simon's point. There's clearly lots of detail, there's lots of spreadsheets. People will crawl all over those, which I'm sure is an essential part of it. But I think on the back of what Simon said, at the end of all of that, we've got to be able to say, what's the story here? What's the narrative? When we're talking to our own people and the public, how is this part of the country going to be better than it was last year or this year? And there's a real danger that you sort of hit the target and miss the point on some of this. You get a gold star for, yeah, a great set of spreadsheets, but actually, where's the ambition? What's the story? And how are people going to say, yeah, actually, I want that as well. I'm sort of right behind you to deliver it. And I think that's going to be a really important part of the process.
And if I may, pre-Christmas is almost a staging post. It is going to be very spreadsheety, numbers based. By the time we get to February, we have to be able to articulate our narrative about our 5-year plan. So what Simon's talking about in terms of having the time and the space to really make sure we're articulating our ambitions, I think that will be the job in the new year to be able to inform that next iteration.
Are we providing that opportunity to create that time and space? I mean, is this conversations that you're having with chief executive colleagues, for example, Simon, so, and to try to start to articulate that vision and ambition?
I mean, some of, and we have Andrew chairs the System Transformation Digital Group, and I think we started to get into that this morning. I do wonder whether the January meeting of that committee just needs to take that on a bit, because we said, actually, what's our compelling narrative? Yeah. How do we take what we've got in our various strategies, look at the planning framework, and then say, so what? What does that mean? And that then needs to resonate and translate back into our plans alongside the individual organisations' commitment to say, we're going to deliver the constitutional targets during 26-27 within the financial envelope. So it's how do we build on what we've done well this year, but then start to set out our ambition for the next 3 years. And so I think we need to do that. I also then probably need to think about a board development session where we pull that together as well before we get to a submission date.
And Roger then, David.
Yeah, I mean, just to pick up that point, Simon, there's a lot happening in terms of the cluster work. I think it's very important that we as a board get that timetable and dates in our diaries as soon as possible, because otherwise we're going to miss that opportunity, I think.
Thank you, David.
Thank you. I guess the strategic intent and ambition you refer to as a value. Each and every item has a value, so that should define the spreadsheet before you do the spreadsheet. Sorry for stating the obvious. So there's something perhaps for future years in terms of timing. I mean, from a local government perspective, this will be the first year in a decade that we'll get a multi-year settlement. So wow, you've got one as well, and I guess you've had those previously at times as well. And having it now, we'll probably get ours on Christmas Eve. Well, I'm exaggerating, but the week before Christmas, but there we go. So I guess my question is to you, Claire, if I may, Chair, is to say, you know, some of the assumptions made for the 26, 27 and the future years, the assumptions made in terms of the gap and bringing back in within the 3-year period, in terms of the information you've received to date, has it wildly affected those assumptions?
So there is some. So this is the equivalent of not muting myself on Teams, isn't it? Dear me, can't how many times. So there are some fairly fundamental differences in the planning guidance to what we assumed when we set the medium-term finance plan back and we signed it off back in June. However, the differences are both in the expectation in terms of some of the performance targets as well as in the allocation. So the central team have, in reviewing the allocations, try to push more locally to give us more flexibility to get things done. So part of the work that we're doing at the moment is very much to say what has, if anything, fundamentally changed since those assumptions, because it will absolutely impact on the gap that we need to close. The initial work that we've done, although we've got moving parts in different areas, it still feels doable from a very high level. And now I know that's not very scientific and that's not how an accountant should speak, but when we bring the numbers, we'll be able to track the art of the possible in terms of the allocation that we've been given. There will be some technical things we need to do without getting into too much detail here. They're fundamentally changing the deficit support regime, but I think at the moment that actually works in our favour as a system because it's giving us time to make that piece of financial recovery. Another example is the elective recovery fund. That's been pushed down a far more significant amount of that for local controlling baselines up front. So we've got a really clear steer of how much activity we can buy next year. So the task is where do we deploy it to get the best impact. As I say, those allocations only landed a week ago. So that's where the job is at the moment, getting most bang for our buck, quite honestly.
Yeah, I suppose what I want to go back to is Claire's very first point, which we never stop planning. And a level of pragmatism here. The first draft has got to be submitted in 3 weeks. And then we've only got 3 weeks after Christmas in the new year before the board meeting that will have to sign off on the final draft, which has got to be in the first week of February. I think I'm right in thinking that's the 2-year plan rather than the full 5-year plan.
2-year finances go in this side of Christmas, 3-year finances, 5-year narrative in February.
So it's just got to be a little bit realistic. And actually, probably the most important meeting we'll have is in the second week in February when the numbers have been submitted and we're sitting down and thinking, right, what are we going to do? And how can we then build on that all the way through? So it's just a sort of, because we obviously discussed this at the Finance Committee yesterday, and I could see some of the faces around the table from the finance director saying, we just got these numbers last week. What are we going to do with them? So I think it's just important to recognise that. Nitty.
Just quickly, just a quick question on the financial planning. There's quite a lot in the 10-year plan on the programs that, are being pushed through. Is there any extra funding for that or not? Or is it in the general allocation? Are there any targets set aside for that we should be aware of so that we're kind of following that story? And then finally, if you're not being scientific, neither am I, sorry about that, is do you get a sense of where we're going to be pushed to spend our money, really? And will it be, it'll come out in the planning, I'm sure, but it never is enough. We all know that. So just asking that unscientific question.
Yeah, we have a few very, very clear signals that fall out of the 10-year plan and that are a thread through into the planning framework. So I've already mentioned the elective recovery fund. We're being asked to push hard to recover waiting lists. So hence the focus on that. We've got quite a significant change to how we cost and charge for urgent care activity, which is another big piece of work that we're looking at the moment, again, to allow as much flexibility as possible in the providers who need to deploy their resources. There's also some clear steers in there about how we allocate the additional allocation that we receive. So some asks around how much growth goes where. So there's a very specific support to the left shift and an expectation that we drive that change. Now, you recall when we set our medium-term finance plan, we had got that left shift over time. So that's something we'd already factored into our thinking. But what we're doing now is testing, do we go hard and far enough compared to that expectation? And we're still receiving some of the service development funds, which would be targeted to specific areas. And I think, Nitty, to mention the D word before you do, digital, there is a national there's a national capital fund for digital that our teams are working on the moment to have at the moment to have business cases ready when we understand the bidding process for that, and all of that is there to support that work for the left shift as well. So it's all hanging together quite well.
On the digital side, if your teams need any help, please do ask. It's what I do for a living worldwide. I do have some experience on that. So if anyone's interested, I'm happy to chat to them.
Thanks,
Simon, then Terry.
So a couple of bits, and Claire touched on one of them. In the planning guidance, there is an increasing push in terms of deconstructing block contracts. So what does that actually mean in terms of taking the block contracts and looking to understand them better and break them up? I think we're all really clear around this table, but just for absolute clarity, the intention here is not that we revert back to how do we count every widget and get into letters backwards and forwards. This is about how do we support the shift from hospital to community and do that in the right way. And I think we've got the structure with the group model and with our approach towards neighbourhoods and with our place boards that we've got an opportunity to really think about that in the right way. So let's just make sure we use that in the right way. And then the second aspect, in terms of that thinking around our narrative going forwards, I guess it's a David and Tanya for your help with the two place boards, because actually I think having the two place boards having informed conversations around what that ambition might look like and making sure that's then able to feed through into our narrative that comes back will be really important aspect of this, because otherwise there's a risk it's top down or it's done from a distance, and I think that would be given the maturity of where we've invested and developed and where our local authority chief execs have taken those place boards, that would be a missed opportunity if we don't use them to then help shape what our narrative is.
Terry, then we'll pull this together.
Thank you. Yeah. Just talking of a shift to the left in allocations and a brief point, in the light of the new cluster arrangements, colleagues in Staffordshire and Stoke have a well-developed VCSE infrastructure model. I'm not entirely sure, well, I'm sure that we don't across Shropshire, Telford and Wrekin, which creates somewhat of a risk of an equal community voice and intelligence across the cluster. So it'd be helpful to understand how the ICS plans to balance that so resident voice remains consistent.
So, interest in that?
I don't know whether Simon wants to comment more on the VCSE model. For comfort, right now we remain two statutory organisations, so any work that we do in STW will be focused around our existing community. Obviously, if there are areas to learn from and there's things we can build on, why would we not do that? But for now, there's no sense of kind of a lost voice in that cluster structure, because we have a very specific responsibility to the community as it stands at the moment.
Yeah, because I also accept, Terry, I think your challenge is what can we do in STW to develop in a similar way as the investment in SSOT. I think that I'm going to be honest with you and say it's going to take a little bit of time just to make sure that we understand what that looks like. But as Claire said, the intention will be if the clusters to build on and get us to an improved place, we need to learn from the two organisations and the two systems in terms of what works and what's positive, and that will be on both sides. There will be learning in terms of that, and that's one of those areas that we need to get up to speed with and understand what that looks like. So noted, heard, not yet at a point where I can respond fully and say, and it's going to look like this.
Can I just make a quick point on elective recovery, please? Just on that bit of it. Sorry, I can't see the room very well. So if I'm speaking out of turn, I apologise, Ian. On the elective recovery fund, there is another D word, Claire, which is an important one, is diagnostics. And none of your elective recovery is going to work without kind of the access to diagnostics, because that's where it gets blocked mostly, a lot of times, particularly on cancer elective recoveries. And cancer diagnosis, which we're falling far behind on. Everybody is, well, we are as well. So just a question or just a point that I needed to make, that whatever we do on elective recovery, we keep in mind what the diagnostic pathways look like and where we're commissioning our diagnostics from properly. The other issue is it ties nicely into digital, is how we actually look at some disruption in the diagnostic pathways, especially on point of care testing. I'll stop there, but happy to talk further if anybody's interested in that.
Yes, so you saw me get triggered there, didn't you?
I did.
And I've got it ready for later, and it is a SAF perspective, but given that's where the bulk of the weight's been. As of the end of October, the trust is one of the most improved in the country for electives. in terms of the number of patients waiting over 52 weeks, it's gone from 7% to 0.2, and it's actually close to clearing it, which is years ahead of where it needs to be. Sorry, Nitty, I've not finished because I've got a bit more on my list. In terms of 62-day cancer, we've just put our best month for 18 months. 28-day faster diagnostic, it's our best on record, and actually we have improved it in October. And diagnostics, we've just done 6 weeks, it's our best performance of 5.5 years. So I'm really sorry, but I'm just thinking of 8,000 staff who have worked incredibly hard, because I think there's something about the narrative. We have still got a tiny way to go and to continue, but we are miles away from where we were 12 months ago.
That's lovely to hear, and really nice to hear that. I'm just asking us to keep in mind that diagnostics is always the issue from a general practice perspective as well. So just to remind ourselves of that, it's not just diagnostics sitting in the hospital, but it's also we're moving to left shift, and you want people to move left shift and to refer less and to have the right kind of treatments in the community, then diagnostics becomes a really important issue.
Thanks, Nitty. Phil, then we'll move on. Phil, can you bring on Michael? Phil.
Sorry, I'm new. Sorry. So another D just to introduce is demand and demand management, and making sure those pathways are working right, because certainly other areas I've worked in, we do see higher than expected levels of referrals for certain diagnostics. So we need to make sure, as part of the piece in terms of addressing diagnostic waits at all parts of the pathway, that we are ensuring that those who need those diagnostics are having them, and we're not carrying out unnecessary diagnostics. But I think that's part of the whole pathway work, and indeed looking across the left shift as well. I just wanted to make the point that it's not going to be purely about doing more and more in the acute.
Yeah.
Thanks. Thank you very much, everybody. Really good discussion. I think what I'm hearing from colleagues is there is a timetable that we need to adhere to. We need to adhere to it. We need to make sure that we're clear in terms of the decision-making processes, both in terms of for providers and also for the system, and make sure we're building that in, as Roger said, as soon as we're able to. An opportunity to be clear about what our ambition is, and doing that in the context of, for the first time, we have the ability to plan beyond the 1 year period, both in terms of revenue and capital. And actually that gives a massive opportunity for the system to be innovative, to be creative, to start to articulate what our ambition is for our population, and to also see that followed through with very clear plans and actions. And that's, it's a short timescale to do that. But let's see if we can grasp that opportunity to our best endeavours, so that actually that we are demonstrably seeing improvements to our population, as Joe's just clearly articulated in terms of the diagnostic performance of staff. So I think we're asked to note the report at this point in time. Is that all you need?
Yes, thank you.
Right, thank you very much. Then moving on then to item 238, which is an EDI update. Unfortunately, Vanessa's unable to be here. I suggested we take the report as read, but any specific issues or questions that anyone has in relation to the EDI report, and perhaps frame it in the context of the excellent presentation we had at the start of our meeting, but also the very clear focus around anti-Semitism and other forms of discrimination that has been impacted upon not only staff but patients. Simon.
So this has been a board priority, hasn't it, for a period of time now? I think the important bit here is how do we, and we heard it from Sherilyn, how do we continue to ensure that this gets embedded beyond a board conversation, so that it becomes business as usual and core business, but core business in a way that is front and centre in the way that we deliver care to best meet the needs of our population. And I think the paper and the regular updates to the board help to reinforce that. I recognise that there are regular updates going to provider boards as well. It will stay as a live narrative around this table, but actually the best examples of that is at the start of the meeting today, and hearing that, because that's then where we're starting to go round and complete the circle in that space. But it's more to do, but making sure that this board's continually got a live narrative on this agenda.
Any comments?
Yeah, I think a lot of progress has been made. The one bit that came out of the report that perhaps we need to think about more is actually the reporting of race-related incidents. And that was the one bit that didn't seem to have had the same improvement and notice that it could have been. And is there more that we can do? Well, how are we thinking that we could make people feel more comfortable about reporting these?
Thanks. Come back with Tanya.
Deborah took the words out of my mouth. So welcome the report and a key priority for this board. But the leader and I from Shropshire Council have recently met with a number of staff who are raising increased racism in our county of Shropshire, particularly from our community workers. And so, like Deborah, I would like to be looking at specific actions around how do we support our workers to report racism, but also how do we support our managers to know how to respond to that. And we certainly have got an issue here in the council around supporting our staff both ways of doing things differently. So I think as a board, it would be really good to see specific actions on that.
And it could be cited as well in terms of the different ways that people might feel confident about raising issues around racism and other forms of discrimination, and whether that's through the formal contact with their line managers or whether through the freedom to speak up processes. It's good to get that rounded picture, and perhaps we're just seeing snippets of it at the moment and we're not bringing that together in one piece. But
can I suggest as an action then that Vanessa picks up with Tanya the conversation, because I think there's probably can we join some and put some more thinking together, because actually we can work in partnership on some of this, and because the same challenge for provider college, general practice, that confidence of ability to speak up, but then knowing that when you do, it gets heard and gets acted on in the right way in any form of discrimination is really important. So I think we can think about something that's across the ICS around systematically how do we do that in a really good and positive way, and our board leadership then is to set that narrative of why this is important and why we back this.
Because people will be facing discrimination in the workplace, but also in society as well, around racism, misogyny, homophobia, other forms of discrimination. What's our responsibility as leaders in the healthcare system to say, actually, this is not tolerable? And actually, it's really important that there's sometimes need to put a stake in the ground to say this will not be tolerated. And how we then respond to that is something that different providers will need to consider as part of their own processes and systems. But I think sometimes saying things and being really clear in terms of those statements is an important first step. But Terry.
Just to add, if there's any work we can do from the voluntary sector perspective, joining you on that, we've done some excellent work with Stop Hate UK. We've done work with health and local authority systems across the country in supporting better reporting for staff, residents, patients.
So let's take that as the action that Simon has recommended to ask Vanessa to work with colleagues and partners to see what more that we need to collectively as part of a very clear response to the challenges around discrimination that people are facing in the workplace and beyond. Happy to agree with that recommendation. Great, thank you very much, and great report from Vanessa. Moving on then to the GP patient survey, Lorna.
Thanks, Chair. And so I'll take the paper as read, but the paper presents the results of the GP patient survey for 2025 for Shropshire, Telford and Wrekin. I'll just pull out a few key findings. So we had a response from around 5,800 of our patients, about 37% of the population, which is a reasonable response rate in terms of what we see nationally, although recognising that we would like to see more. The data does show a moderate improvement overall compared with last year, although we do see marked variation between practices. Headline results are that the overall experience was rated as good for 75% of our practices, which is round about the national average. Ease of contacting by telephone, 63%, which is down a little bit from last year and down on the national average, so will be a focus for us going forwards. Ease of online contact, again 63%, up on last year, but still below the national average, and I think we all recognise that there are challenges around digital inclusion in Shropshire, Telford and Wrekin that we're working in partnership with the local authority to try to improve. Appointment wait time about right, 69%. So again, an improvement on 2024, but just below the national average. And clinician interactions rated as good in 68%, which again is up on last year and above the national average. So headlines being that consistent confidence in our clinicians and year-on-year improvement in terms of our access. We have a range of performance, as I said before. So our highest performing practice, 96% of their patients reported that their overall experience was good, which I think is nothing short of exceptional, but something that all practices, I think, would aspire to. Our lowest performing practice in comparison, only 45% of their patients rated their overall experience as good. That said, the GP survey is only one part of the information that we use to consider how well our practices are performing. We use data from the National GP Dashboard, which gives us lots of information about same-day access, 14-day access, practice staffing and patient satisfaction. We also use locally collected data, and we go out and we talk to practices. We do quality visits. We engage with them to understand what their challenges are. None of our practices go to work every day to do a bad job. Often challenges in terms of access for patients reflect challenges in terms of practice staffing, demographic growth, various things. So it's important that we recognise those. So real positives, we've got 12 practices where the satisfaction was rated overall as good, overall good greater than 90%. And we've got year-on-year improvements in the waiting times being about right and in online access, recognising we've still got challenge around access and telephony, digital inclusion and equity, because when we look at our highest and lowest performing practices, you can absolutely see the correlation with practices in smaller rural areas where the way of practicing is very different, the needs are often different and the access is different compared to our areas of urban conurbation where we are seeing consistently concentrated less good ratings from patients. So there's something for us to think about in that and how we work with practices to resolve the needs of their particular patients. In terms of pharmacy, community pharmacy, 87% of the patient experience of our community pharmacies was good, which is round about the national average, and our dental practices, 73% of those practices overall experience was good, which is above the national average. I guess the main point is the so what are we doing as the ICB and as a primary care team to work with practices to improve where we can. So there is the practice level support scheme, and we currently have 7 practices who are working as part of a national scheme to support them with various pieces of work to improve practice flow and improve and learn from initiatives and other practices. All of the practices in our area that have negative variation against national indicators were offered a place on the scheme. It is voluntary, but our practices, the majority of our practices have engaged with it. And in fact, some of our practices have engaged despite their indicators being good, hoping to learn to become better. We're also investing in peer ambassadors, so we are looking at high performing practices and trying to take the learning from their practice managers or their lead partners or whoever it is that is driving that good practice and that good service for patients, and then using them to help us disseminate that to other practices. We have obviously quality visits, monthly feedback and meetings with practices where there's negative variation. And we are also working with our local authority around that digital inclusion piece, particularly around access to online booking, online consultation and the NHS app. So I'll stop there, Chair, and I'll take any questions.
Thanks very much, Heather.
2 things. You need a community pharmacy for it to be rated, and there are great swathes of the countryside that doesn't have one, and therefore there are all sorts of access issues. So I'd quite like to see that reflected. It's good to talk about the ones we've got and look at improvement, but actually we need to improve access to them. Secondly, the digital stuff. there is a major setback at the moment. And that is in many of the rural areas, fibre to the premise has been set right back. It's not going to be delivered now by 26. It's going to be delivered hopefully by 2030, and the number of properties within Shropshire that are going to be connected are less. So any digital programme that you're talking about, you need to be doing that very much in talks with us, because we know exactly the issue. And it's really difficult then to put the education in place for those people if they have no access to any of those things, not just with mobile hotspots, but actually to fibre and broadband and so on. So there's a whole bit that actually isn't reported on there that actually needs to be taken into consideration and measured in its own right.
Thanks, Heather. Really helpful. I'll come back in a moment. Nitty.
Just quickly, I'm a rather old lady, so I'm able to say this, and I've been in general practice for a very long time, giving up my license this year. But just on that note, performance has always been judged on the GP survey on access, and rightly so, because that's what our patients and our customers expect us to do. But I've been banging on about this forever. How do we triangulate this with outcomes? So it's great to have the access, but actually if your patients are dying early and they're not being treated for the high blood pressure or the diabetes, it's of no use to have the access. So really, my question to you is, we've used the National GP Survey and we've done what we've done and we've got what we've got. But we're talking truly about a left shift, and we're talking about moving the needle to that left shift and population health management, getting better outcomes for our patients. We've got to triangulate patient experience, both with clinical effectiveness and patient safety. So we've got to look at ways of doing that. It's not rocket science. It can be done. And I think we have enough data now over the years to be able to do it. So I'll stop there, but I think it's a really important issue when you start discussing where you're going to invest to really start to see what difference we're making.
Thanks, Nitty. Really important. David.
Thank you, Chair. Thank you for the report and the presentation. I guess mine's around the lower performing practices. 6 are quoted, 3 in Telford and 3 in Shropshire, I guess for equity. I'm not sure. There we go. But the 3, I'm going to refer to the 3 in Telford, all covering our most deprived wards, 27 wards in the top 10% deprivation in this country. They're not all in those 3 wards, but there are some. And I guess my question is, what are we going to do about it? It's just not good enough, is it? And, this is covering a population of about 60,000-ish in Telford. So I guess I'd like to see from the perspective of the board what actions we're going to take, and not in this meeting, but I need reassurance that we're going to make a difference this time round. Without this survey, we both could have been very clear about what the results would have been like. Probably wouldn't have had the numbers, but perception of it and knowing our place, we'd have known the outcome of this. So we need to do something about it. Thank you.
Right, so I think that let's come on to that in a minute, because I think it's really important that we're really clear in terms of the so what are we going to do now. But Ian's, I know, keen to contribute.
Thank you, Chair. This is very much follow on from Dave's point. We know that areas of high deprivation typically have a higher health and social care needs, and therefore access is also higher. What we're seeing is the realities and manifestation of the inverse care law, where good medical care varies inversely with the need of the population it serves. So essentially, who needs their health care the most, often are the most socially disadvantaged and are least likely to receive it. I think a lot of this issue is beyond ICB. This is very much about how GP is being funded. So specific focus on GPs. GPs in its core contracts is universal, which is based on disease prevalence, but not deprivation. Therefore, health inequalities, especially GP access within the deprived population, can't be solved without a more proportionate funding envelope. But fortunately, there is currently a national review of the GP funding formula, which is very welcomed. But the greater question is whether, if there's going to be a change in the GP funding methodologies, will this extend to the wider future of neighbourhoods? So, again, this is not an issue for ICB, but it is a national issue how to be funded. So I just want to make sure that ICB needs to continue and support our local practices who are operating under such constraint in a constructive way to continue improving health outcomes.
Thanks very much, Ian. Laura, any sort of response to the points have just been flagged?
Yeah, so first of all, on the point of community pharmacy, absolutely right, and completely agree, Heather. I think it has Sorry, absolutely right. Completely agree, Heather, on the point of community pharmacy. Community pharmacy are becoming increasingly important in patients being able to access care. They're delivering more and more in terms of clinical services, and in fact, those clinical services are supporting the financial viability of those community pharmacies. So it is really important that we look to expand that offer, and we also look to expand the opening hours of those community pharmacies that are already there. So certainly something that we've been in conversation about, and we are really working towards recognising that as a real issue. Digital inclusion also, there is no argument that Shropshire is, many parts of Shropshire are at an extreme disadvantage, and those practices where that is the case, I think they would all recognise that is the case for them, and have adopted their models of working to try to support that. That said, there is a very strong national drive around digital access to general practice that many GPs themselves are a little bit uncomfortable with, if they're honest, but it is the national direction of travel. It's about making sure that we have got an offer for those where there is that exclusion, and that they are not disadvantaged by that. In terms of I'll come to your points next, David. I think that what I really was pleased to hear you say was, what are we going to do about it? Because actually we all know that access to healthcare is only 20% of people's health outcomes. I bang on about it all the time, but the other 80% are those wider determinants that we can only move the dial on by working in partnership. That said, we absolutely do need to make sure that those with multiple disadvantage, those living in deprived areas, are still able to access the services that they need. And I think as we move towards our neighbourhoods, that's going to be one of the keys in terms of aligning our services, looking to become much more granular in terms of the needs of those populations, meeting people where they are rather than necessarily expecting them to come to us. Shifting to prevention is going to be absolutely key, because unless we do that, we will not ever get ahead of this reactive phase that we're in. And then in terms of, kind of Ian's point, absolutely agree that we are seeing the inverse care law it playing out, but we shouldn't just accept that. It isn't, we are able to identify health inequalities. We are able to start to target our resources to tackle inequalities in a much more granular way than we've ever been able to do before. And it is about how we as a system start to prioritise or continue to prioritise doing that, working in partnership around those wider determinants. And that's the way that, that we plan to work moving forwards.
Lorna, that's really helpful. How are the key findings of this specifically taken forward? Where's the forum for this? Or there might be a number of fora.
Yeah, so the actions are owned by our primary care commissioning group, which then feeds up through our strategic commissioning committee and up to board in that way. So you will see, the board will see as part of the SCPC report, those papers and that report come through. And obviously happy to bring updates at any time that the board wants to see them.
Sure.
Thank you. Two questions. It was interesting, David's point, because one of my questions to you was going to be, were you surprised by the results in terms of the practices that didn't fare so well? Was it a surprise to you or not? So interesting that it wasn't, for David. My second point is, interesting on the peer ambassador programme. In principle, it sounds great. In my experience in the past, they've often not been, that type of model has not been received particularly well by the lower performing service, whatever that might be. Do you have a sense of how this is going to be perceived?
So on the peer ambassadors, I think we're pretty early on in the programme, but actually most of our practices, because we have a smaller number of practices with 50, they know each other well, they get on well generally, and are supportive of one another. So those relationships, I think, or I hope, will breed that supportive view rather than the sort of, we're coming in here trying to tell my grandma how to suck eggs type of a thing. And I think, they are all in a positive mindset, looking to do the best that they can. And so, learning from best practice, taking those efficiencies. I think the conversations that we've had with practices that we think may benefit from the peer ambassadors is to say, we absolutely recognise that this is, you know, nobody goes to work to do a bad job. This is a supportive thing. This is absolutely about learning from one another, and what there will be things that you do that other people can learn from as well. So we're taking it in a supportive way. It's being at the moment received in a supportive way, and I hope that the small number of practices will allow that to carry on. In terms of was I surprised? No.
Jess, then Roger, then we need to move on.
There we go. Apologies for being late. I've just been over with Chris Whitty over in Highley, which just of note is the most deprived place in Shropshire, but isn't on that list. So kind of does put my friend slightly. On the digital front, I've had two experiences recently. I was at a meeting last week with the chap who's the lead for the NHS app and NHS Digital, who told me that AI is going to take over the world and I won't need to be doing a job anymore and it's all wonderful. And sort of didn't really acknowledge when I asked about digital exclusion, which was slightly worrying. But thankfully was then followed by a chap who basically said that AI is useless and it won't be doing anything and actually you need to be doing something else. So that was really helpful. But we've just literally had that conversation about digital exclusion with Chris Whitty in Highley about the use of, say, telemedicine and actually how that could potentially have huge gains for us. So, for example, the Highley community not having to drive an hour plus to come over here, but needing to have the governance and all that stuff around it, but also that we genuinely have populations who do not have an internet connection. So it's trying to marry those things up. And there's certainly acknowledgement from him in terms of the digital push and where that's coming from, being more sort of younger populations who are very IT literate in central London, rather than actually understanding the reality of things. So actually, I think it is fairly well understood with some people, the issues we face. And I guess that's something that we're just going to have to sort of grow with. And certainly the change in pod has actually been quite a positive thing for quite a number of my patients. I was to the flu clinic saying, how do you order your medicines? If they said the pod, I said, right, well, things are changing. And that was really interesting because I found that if I said the app, they didn't want to use an app, but they would use the button. Because they've got a WhatsApp group, they see the photos of their grandkids that way. So if you said, well, can I put the NHS button on your phone? Yeah, by all means. So actually, some of it was just trying to communicate that. Some people generally didn't have an email address, but 5 minutes later, I'd sorted them out. So it's all completely doable. And actually, that a lot of this, people can grow. Yes, there are a population who won't be able to, but it can be overcome.
Yeah, thank you very, very quickly. Just a couple of points. First of all, does this report go to the GP board for discussion?
It's not the place of the GP board. So I guess not necessarily discipline, but it's not our place to come and practice. We're there to represent the practice. But if someone came to the GP board saying that they had an issue and wanted to discuss it, have support, then that could be either for us or the LMC to I guess, address. But it's not necessarily the GP board's place to say your performance is lower than somebody else's. Just like there's a PCM thing director, our contract isn't to get involved with people's patient satisfaction. Do I get the data sent past me? Sometimes yes, but actually it's part of the contract as CD to bring that up with practices and address with practices, not directly. If practice comes to me and says we're really struggling with capacity, which was kind of a roundabout thing about how everything ended up happening at Highley, was they're really struggling with capacity, and the JSNA said that, and the figure said that, and CPC said that. That's when we get involved. But the only way that we managed to get involved in the end was that contract got handed back. You can't force anybody because it's their business. It's really hard to kind of exert any influence. You could say your performance figures aren't that good. Is there anything we can do? But the influence that is either the CD or the GP board chair has is quite limited. That makes sense.
So I'll leave it. Okay, thanks.
Anything funny to say?
No, I think that's a really helpful discussion. Thank you.
So let's take us very quickly, because I'm very conscious of time. But
very quickly. So just to say, I mean, it'd be remiss of me not to mention our GP access survey from a health perspective, and the offer is there to bring those data sets together. So we saw responses from over 9,000 individuals across Telford and Wrekin, and there's synergy between what we're seeing, but we came together with a lot of recommendations, and so it'd be good to work with the PCNs on that.
I'm going to need to move us on now. So can I suggest we take as an action that this will go through the normal governance channels, but I think that have an updated report to the board in terms of any specific actions being recommended in the light of that, how it's been socialised, but also particularly focused around the 6 practices that have been identified. Great, thank you very much. Moving on very briefly to GP out of hours update. Again, there's nothing here that we will be asked to do is to note anything you want in particular you wish to draw to our attention. We've read the report.
Just to say that just to bring to the attention of the board, the mobilisation period that was very, very compressed, but the very can-do attitude and solution-focused attitude that Health Hero came with, and the slightly bumpy mobilisation the first couple of weeks that are described in the paper. You will see, however, the response times and the patient experience reports are excellent and are well within the set limits. So the service performing very well. We continue to maintain oversight of the quality, so the ICB quality leads liaise very closely with Health Hero, and those the outputs of those meetings and any patient incidents, there haven't been any so far, are monitored by the Chief Nursing Officer and myself on a weekly basis. A thank you to Health Hero in terms of how hard they've worked, and as a system partner as well, and recognition of the good patient feedback that we've had on the service so far.
And that's one. I understand that the relationship with partners is also positive in particular for us.
Yeah, thank you. So calling them Health Hero is exactly what they've been, to be fair. They've been incredible. I do want to just pick up in terms of the point Lorna's made. Not only are they visible on site, they're on site as much, if not more than me on some of the sites. So Quay and the Associate Director both sit on the UEC board, but they also came to a multi-agency event that we did last week at RSH, but also with WMAS in terms of what can we do in terms of improving it. So there's a lot of detail in the paper. It was not easy for them to take this contract, and they've just run with it. And we've already seen a 10% reduction in terms of conveyancing, and the last element of the work that we're doing on now is the bed bureau, but I think this will just continue to flourish.
Thank you, Heather.
Just a question about those cross-border and postcode issues, whether you're getting any reports that actually people being diverted to the wrong places, because that always used to happen, and therefore I'm interested in whether it's still happening, especially if you have a Welsh postcode or a Welsh phone number, but it will happen in other places as well. So a report around that would be very useful, because getting that right is fundamental.
Take that away.
Yeah.
Yeah. Thank you. Sorry, Deborah. Let's start.
Just a very quick one. I think I'm really pleased to see how well things are turning out and how things are improving. It was a really bumpy first week or two, and I just wondered whether there are lessons that can be learned from that. I realised some of the bumps were beyond individual organisation control, but are there lessons that can be taken away for future procurement and changes in providers that hopefully would minimise future bumps?
I think it's fair to say that I don't think we've experienced the challenges that we experienced in the relationship between the previous provider and the new provider. I don't think we've seen challenges of that to that extent before, and I would be very surprised if we were to see them again. I think it was exceptional, and there are always lessons that we can learn in terms of kind of efficiently navigating the representation process, which we did, but recognising that actually it always takes longer than you think it does. We still have the issue described in the paper around the controlled drugs licence, which is ongoing. It's a national process that we can't influence, but again, making, it takes a lot longer than you think it does. We've worked around it, and I think there's a lot to be learned from how we've worked with partners to put in those workarounds. That's positive. but I think, yeah, it was an exceptional situation, and I think most of it we would hope not ever to see repeated.
Thank you, Simon.
Yeah, I mean, I think Lorna's answered that question well. I think the other piece for me is just to be really clear. This is, given the noise and the challenge around this, this is our commitment to be completely transparent to the board. Hence why I recognise something like this wouldn't normally come to the board when you do a re-procurement, but given the impact on the local community and given the noise, we made that commitment to continue to be transparent. So hence why we're bringing that back here for the board in public to have full visibility of that and to have the debate and conversation about it.
Thank you. And but I think that the proposal now, though, this becomes business as usual. So I think that we're in the same way that we manage other contracts, we do that in exactly the same way. So probably it's the last report we would have in this form, unless there are particular issues that should be flagged through our normal governance processes. Okay, so sorry, Jack.
Apologies, just
yes,
to say, we'll also pick it up through the UEC board.
Okay, perfect. Thank you very much. Let's then note the report, note the challenges, note the early impact on the service post the 1st of October, and note the move to business as usual. Let's have a 10-minute break. Let's come back at 25 to.
Chair.
If I can ask colleagues to resume their seats, and we'll begin the rest of the meeting following our break. So we have a range of system integration reports, and again, reports from different parts of the system. And again, if colleagues can assume that everybody's read the reports, just pull out any particular issues. And we first of all move on to the Shropshire Place Partnership Committee. Tanya.
Thank you, Chair. So I take the paper as read, including the minutes. So last meeting was 16th of October. Very well attended integrated place partnership with Shropshire One is. Our partners always turn up, energised and engaged in all of our meetings. You will note the items that were discussed. So there was an introduction to the National Neighbourhood Health Programme, but I know that this board received a paper last time round. There was an update on the Shropshire Integrated Place Partnership Prevention Fund and the Shropshire, Telford and Wrekin Healthy Ageing Strategy, and also the vaccination improvement plan and the introduction of the out-of-hours GP service. I've noted in the TWIP report around the request to share the learning from the National Neighbourhood Health Programme, and I would absolutely endorse that. And in terms of getting more regular updates into this board around the great work that we hope to see through the national programme would be also something I'd like to recommend. So thank you.
Thank you. Any emerging risks that perhaps have not been highlighted before that came up through that last cycle of meetings?
No, there was no risk raised at that meeting.
Right. Okay. Questions or comments, Nigel?
I think just to there's a lady in Shropshire Council, a lady called Naomi Roach, who has been extraordinary in the work. I know from the ICB, we've got a couple of key folk there, really working hard. But I would really just call that out, and she's been fantastic. So thank you.
Thank you. Any other points? Okay, can we note the report? Great, thank you. Moving on to Telford and Wrekin, David.
Yeah, thank you, Chair. The board are asked to note the recommendations in 1.2.1. I guess particular note is we asked for a current status of the children's mental health and wellbeing priority, which is one of our priorities in TWIP. We've received various information and various information about, I guess, preventative programmes that are in place, but the board have asked for a further session around this in a workshop, actually, in terms of developing a future, I guess, a better understanding of what's available and fundamentally an assurance, because we don't feel assured at this point. So there'll be a bit more work doing around that to make sure we're doing absolutely everything possible to support our young people. Also to note is the delivery of the ICB funded preventions, the initiatives delegated funding that come from the ICB, which is very welcomed, and all those schemes are progressing well. So thank you for that support. And that's probably it for this moment, Chair. Thank you.
Thank you. And I just noticed that you considered the National Neighbourhood Health Guidance, and again, I presume that's going to be something that's going to be on both of the place agendas over the course of the next couple of months.
Yes, absolutely. And as Tanya said, the learning from that programme as well will be really helpful. Yeah. And we're nearly over it that we didn't secure that. Thank you.
Yeah. Nearly. Any other points for David? Right, we note that report. Moving on now to systems governance and performance, integrated performance.
Thank you. I think, Joe, actually, you've already highlighted some of the good news that we've got in the report. No, don't be sorry. It's great news to share. I think the good news from my point of view, from a reporting perspective, is there are no material shifts to talk about. So we've got the good news in terms of progress we're making over a longer term, but there's nothing of highlight between the last time I reported and now. You'll see from the report the continued progress we're making in that elective recovery, in our non-elective delivery, though notwithstanding, we still have some challenges, and we are working very proactively across the system to address those. I think just to highlight for month 7 finance, we remain slightly ahead of plan. We're still forecasting that we will meet the plan that we signed off, which is great news. We do have a small element of net risk that we're reporting at the moment, which is around £3 million, and that resides in SAF. But Andrew, Joe and board are proactively managing that with a commitment still to deliver plan. The only thing that I did want to highlight, which isn't in the report, but I think is of particular interest for the board today, is that month 8 for finance is a really critical month. It's our last staging post for the release of this year's deficit support funding, and we have 2 tasks to fulfil for that last piece of funding to be released. First of all, we've got to hit our year-to-date position. Which from the results that we have so far, I've not seen any indications that that will be difficult to do, which is great. The second thing that we will need to do is make sure that we can assure NHS England that we are confident in delivering that outturn position. We touched on it briefly at System Finance Committee yesterday, and directors of finance are very much all over that, and have started conversations with our regional colleagues at NHS England to make sure that we're giving them everything they need for them to be able to take that assurance forward and recommend to release the funding. So next board will report on that, but I just thought that was an important one to flag here today.
Was that an internal assurance process that you will be providing that assurance?
Yes, we'll manage it through our usual conversations with NHS England.
Okay, right, okay. Again, if there are any doubts about that, don't hesitate to rope Simon and me into those conversations as well. But it sounds from what we know thus far that that's something, that hurdle is one that is we should get over.
Yes, yeah.
We need to get over it.
Absolutely.
Yeah. Okay. Any questions or comments? Phil? Then,
thanks. Yeah, I think Joe and I may just do a bit of a double act just briefly around winter, if that's okay. Just picking up the UEC side. So at the last board on 24th of September, the winter plan was approved and board assurance statements were provided to NHS England. I think at the time when Ian Bett was here, he briefed on a number of key risks. Firstly, around some of the leadership changes. The fact I'm here now shows that gap is now addressed, but also other things about the Health Hero transition that we've heard about today, and then also around mobilisation of schemes both in hospital and out of hospital. I think really positively we can say that we're doing well in terms of that mobilisation, and Joe will be able to update particularly around SAF in a few minutes. What I would say though is that the winter plan on paper is one thing, but deploying it and ensuring that it remains effective as we go through winter is really, really important. We track closely the UK HSA data around the prevalence of particularly respiratory conditions, and we know that flu A, B, and indeed we've seen COVID as well, but are very much on the rise, and I think we're about 4 weeks ahead of the predictions that they were expecting nationally around that. So there's a role for everybody here in terms of making sure we're doing everything we can at each point of the pathway to mobilise schemes. But I think from what we've seen and what certainly we talked through yesterday at the UEC group, we're seeing good progress with mobilisation of those schemes. Jo.
Yeah, thank you. So in terms of, clearly it was part of the winter plan, but also the work that we started in February. I think people have been wondering why I'm counting my sleeps down, thinking it was for Christmas, and it's not. It's the capacity that's going online. So on Monday at RSH, we did the reconfiguration of the acute medical floor. On the 1st of December, 56 beds are handed over to us. They are completed. Patients will move into those. So there's a phased move, 8th of December, 22nd of December, and also on the 29th of December. And also we have opened this week, ready for patients going in on the 1st of December, a new discharge lounge that's got 16 spaces in there. We didn't want to miss PRH out because we realised that obviously the space in that footprint also needed to expand. So the board made a decision in terms of a further £1.7 million worth of investment, because we know we wanted to do better for patients. So there is on the there's another 40 assessment beds and inpatient beds and trolleys across. They go in place on the 15th of December, the 22nd of December. And there's there's a frailty unit going in on the 1st of December. I would suggest you don't stand still in any of those two areas at the minute because you're likely to get moved to a new space. The other thing is clearly it relied on Shropcom, who have done a huge amount of work in terms of the services that needed to be in place. So on the 1st of December, we've got extended urgent community response until 7 days a week. Also on the 1st of December, rapid access for bridging domiciliary care goes in place. And also we've got practitioners at the front door across PRH and RSH that went live 2 weeks ago. And so an awful lot that we've put in, rightly so. We needed to improve access. And just a thank you to Harriet from a comms perspective, because our winter plan also, I can just about work out in terms of things that are moving. We also need our citizens and our patients to know. So huge campaign in terms of accessing the right services. And also we've not been complacent about the work we needed to do, but also to celebrate where we've had success. So what we've tried to do is each week to celebrate how we're working across the system in terms of different press releases. So all on track.
That's really helpful to hear. And I had the opportunity of visiting Shrewsbury a couple of weeks ago, and particularly to see look at the UEC pathway. I could see very clearly where huge amounts of progress has been made, where some of the bottlenecks are, but also how the new modular boards, which by the way are fantastic, are going to have a real opportunity of unblocking some of those pathways. So I think that everything sounds like it's on track. And it's about them making sure that we then have the ability then quickly to respond, I presume, to some of those issues and challenges and those knotty issues that come along on a sort of daily and weekly basis.
Yeah, and I guess I should also just say is that whilst we will deliver the plan that we set for ourselves, we also realise how far away we are from the national target. So we're not complacent about the work that we need to do, but also we've improved the environment for staff. We wanted to make sure we improve the care we give to patients, but also giving them the space. And I think we reflected when we walked around ED and didn't with that actually, that environment for people, although it's busy, it's calm and people can think, and actually that improves the fact that they want to be, they also want to work at SAS, but also improve the care they give to patients.
The other person, Heather.
Can I just make a point? I congratulate you for getting Shropcom to be active and delivering. As Simon knows, I have a long history with Shropcom, and I'm really pleased to see it changing.
Thank you.
Thank you. Any other issues that anyone wishes to raise on the forms report? I guess we'll go on, Phil.
Sorry, just briefly, just to mention the importance of vaccinations in terms of both the workforce, but then just encouraging members of the public eligible for the free flu vaccination to make sure they get the jab, because that really does help us as we work through winter. Yeah. Thank you.
I was going to say that's the one key message I think that we need to take from this meeting today, that anyone who's eligible for a flu vaccination should take it up, because it does have a massive impact, not only to protect an individual, but also in terms of that wider population health as well. Great. Any other points I wish to flag? Yes, Roger.
Just a quick one on the process of admission avoidance, either through the ambulance service or rapid response teams. How is that going?
So we've seen we've got the front door practitioners. They've only been in for about 2 weeks. So I think it's be interesting to see in terms of how that works. I guess the challenge we've got at UEC is at the board is just trying to track all the improvement which Gareth and the team are trying to help us with. The other that the opportunities in terms of call before you convey as well, and that's what Health Hero are helping us with. And the reflection that I think Phil and I were talking to earlier is that what we're going to have to try and do is some of them are myths in terms of we've tried it before, but I didn't get the answer, so I won't try it again. So what we're trying to have to unpick is to say to people, can you kind of, it's that learned behaviours, and actually, can we now make sure that people are aware of what services we've got and try again? Because it 20, we've had, if you take the Health Hero contract, was it 29 years of a contract? That's a long time to have a contractor in place, and also now trying to pick that behaviours and pathways, and also working with the comms team so that people know what's available. But we can bring clearly, once we get out of this phase, really happy to bring back in terms of where we've seen
Yeah,
the improvements.
absolutely. And there's brilliant potential. I mean, this is just the foundation here. I think I've had just over 1,400 contacts in the first month. But when we look nationally at things that have been done around redirection, bringing in other pathways, there's massive potential around what can be done in this space in terms of ensuring that people receive the treatment as close to home as possible. So we're looking to build in all of that into the development plan for Health Hero as we go forwards.
Yeah, no. And apologies, and to allow you to move on. I guess the other thing in terms of the footprint that we've now got with the group. So one of the things that we're now looking at is where we've got MRUs across the county. What's the opportunity with those? Because I am aware there's some days where there's half-day services, there's some days where there's no service. So what we're trying to do now is to understand what do we need to put into those to make those work, because it goes back to the point I think Jess was making this morning. We expect people that they're going to travel an hour to get to an acute. We need to decongest them now, and we've got the properties, we've got the services. We just need to make sure we've got staff working across them. Then,
David.
I just want to reiterate the point Joe made earlier about the improvement in communication from staff. It's evident from place perspective, and so on behalf of our residents, thank you for that work.
Thank you. So any other comment we actually wish to add finally to that report?
Nothing else from me, thank you.
Okay, so I guess there'll be lots of the issues that have been flagged will continue to be reported through the performance report, and it's positive that we appear to be on track currently. And again, the key focus that I've said a couple of times, and I'm sure provider chairs are saying as well, the importance of delivering the current plan, and then making sure that we are then undertaking the preparatory work into next year's plan, so we kick off that next stage in the journey on a solid footing. So that's really key. Thank you very much. Moving on to maternity and neonatal annual position statement. I think you're going to introduce this for us, potentially.
I am, yes, I am. Thanks, Chair. On behalf of Vanessa, who's the SRA for the programme, I chair the LMNS. Oh, sorry, I've done it again, haven't I? Stop. I don't normally need a microphone, that's why. So, on behalf of Vanessa, who is the SRA for the LMNS programme, I chair the LMNS programme board, so presenting our annual position statement. The 10-year plan for England gives renewed commitment to quality and has committed to a further review of maternity and neonatal care, leading to a new national action plan that will be overseen by a task group chaired by the Secretary of State. And in June 2025, the Secretary of State for Health and Social Care also announced a rapid national independent investigation into NHS maternity and neonatal services. Initially, SAF was announced as one of the participants, but they are now no longer going to be one of those participants. In terms of assurance that the LMNS delivers, so we and this is the kind of the data bit. The LMNS programme board meets quarterly, with the perinatal quality surveillance group meeting monthly and feeding into that. In terms of the independent maternity review that was undertaken at SAF, 210 actions have now were allocated. 192 of those have now been completed. There are 11 that remain. All of them are on track for delivery shortly. 7 of them have been de-scoped, as these are for organisations that are not SAF. We are also compliant against all 6 key elements of the Saving Babies Lives programme, which is a set of evidence-based recommendations and guidelines, has 6 key elements, and we are compliant against all 6. We closely monitor the Embrace UK data. STW can be seen that our data is improving across all 3 measures, so measures of stillbirth, neonatal mortality, and then a combined aggregate measure of both. Previously, in response to this Embrace data, SAF did commission an external review of their neonatal services by the Royal College of Paediatricians. There was a supporting action plan, and again, 15 actions have been completed, 9 are on track. 11 haven't quite been delivered yet, but only 2 of those are not yet commenced. And SAF remains maternity services rated as good by CQC, as well as children and young people services being rated as good. Getting into the highlights of what's been delivered under the auspice of the LM&S this year, lots of really important work in terms of we are a single provider LM&S system. We have one maternity provider that is SAF, and it was recommended as part of the Ockenden review that that isn't best practice, that we should be looking to other systems to learn from. So we have formed a bi-monthly learning collaborative forum with SSOT, and we share learning around infant mortality, around birth trauma. We've shared our system maturity matrices and our action plans to try and learn from one another and share that best practice, which is a real step forward. We've had 2 insight visits, one of which is from National NHS SE Leeds, where the feedback was overwhelmingly positive. We've taken part in the MNISA pilot, the Maternity and Neonatal Independent Senior Advocate pilot. It's a scheme running across 16 ICBs in the country, including STW. And the MNISA offers independent support and advocacy to those families who unfortunately have had the worst outcomes from their maternity or neonatal journey. It helps them to navigate the complex systems that are often in place where you want to escalate concerns, or it helps to amplify their voices and promote that learning and change. The STW MNISA was recruited in November 24 and has been carrying an active caseload since April 25 and has received 10 referrals so far. The feedback is overwhelmingly positive from the families. They report changes in the degree to which they feel listened to. They feel that the independent status of the MNISA gives them the opportunity to share honestly their feelings, their experience and their feedback, and gives them confidence that those will be advocated for and acted on, and for many of them has helped them rebuild a relationship with the trust where they go on to have other children. The MNISA pilot is due to end in March. STW have made the decision that we will extend this. The programme may continue as part of the national review that is coming. It may be decided that this is nationally rolled out, but we have decided that it is of such value to our families that we will continue to fund it until that decision is made. Really positive work around the Maternity and Neonatal Voices Partnership as well. So we've recruited a permanent MMVP lead who was working closely with the staff EDI midwife, Sherilyn, who we met earlier, to strengthen that engagement and inclusivity. And we are actively recruiting further MMVP volunteers. And then lots of work in terms of health inequalities. We heard from Sherilyn about the work that she undertakes. We've also had a perinatal equity analysis undertaken in collaboration with our public health colleagues to guide our planning around preconception services and maternity services planning. And we've, on the basis of that, revisited, reviewed and updated the Equity and Equality Action Plan. We've also secured external grants supporting improved early booking and antenatal screening, recognising that our rates are poor in particular areas of the county, and also to support a preconception education pilot. So lots of really good work taking place, and lots more still to do, recognising that maternity care remains a priority as part of the 10-year plan.
Thanks, really helpful to get that thorough overview, and as you say, remains a clear priority for us, both in terms of across the system, but also providers. Any points anyone wishes to raise on that report?
Thank you, Lorna, and it is positive, and I also just recognising when I joined staff in September last year that there were also families that we let down and that Andrew and I have made a commitment that for any families that, first of all, we would apologise to them and meet with them. But we wanted to do probably something a little bit more than that. So we've been working with Mrs. Ockenden to do, we have committed to write to all the families. So Donna has written to over 1,400 families to say that the trust, if they would still like to meet with us, and also to take us through the learning and the improvements, which she has kindly done. I think there's about 154 families that would like to work with us. There is a meeting tomorrow evening that's been chaired by NHS Elect with Donna, and then there's a plan that Andrew and I, members of the board and the team, will meet with those families in January, because I can imagine for anybody reading this, it's quite hard to see in terms of where the service is now, but in terms of where we've let them down. So we just wanted to make sure that we don't forget that, and also to take them through how it is very different, but also recognising that we've let them down in the past.
I think that's important, and that's recognised by the system as well as not just by the provider. So thank you very much for that. Any other points I wish to raise? Okay, we note the report. Moving on now to minor changes to the governance handbook. I'm not going to propose we go through this, but we are looking at, can we agree the proposed changes to the conflict of interest policy and the board petitions policy? Is that agreed? Thank you very much. And we are, just so we're running slightly behind, but let's just move on to the committee reports. And I'll come to the chairs of those committees, and if they've got nothing to say, that's fine. But System Finance Committee Chairs report, Dave, anything you wish to say in terms of your report?
Ian, no, Trevor actually chaired the meeting that we had yesterday, but most of the substantive points have been covered in other agenda items earlier.
So we note the report.
Yep.
Thank you very much. Cheryl, the System Quality and Performance. Cheryl, just
yeah, the thing I'd say is, if you read the report, just to note the recommendations of what of the policies and documents that we approved on behalf of the board.
And those issues you've escalated, obviously those issues around diabetes. and TB as key issues.
And we're receiving a report tomorrow on diabetes. Every quarter we get in presence.
So I presume as well that if you continue to not be assured, you will escalate those directly to the board.
I will.
I know you will. Good. Thank you very much for that. So apart from that, can we note the report? Strategic Commission and Productivity Committee Chairs, that's my report. I'm happy to take this as read. You recommend note the report. Thank you. System Transformation Digital Group Chairs report, Andrew.
Nothing to add to this one. We've had 2 meetings since this report, so slightly out of date. But practicing what I was preaching earlier, we did agree at this morning's meeting that the sort of the narrative bit of what's all this look like when you put all those pieces in the jigsaw box, what's the actual picture on the front of the box. So that will be at our January meeting, but nothing to add to this one.
I think that's going to be a really helpful conversation to have through that group, which will help in terms of the submission of the final plan that comes through before it comes through to the board. Note the report and the updated recent meetings. Great, thank you very much. Then we move on to the Strategy and Prevention Committee. Kathy's not here, but Nigel, anything you wish to pull out for us?
2 quick points, just reiterating there's a really close work with health and wellbeing boards, just to make sure that we cross-reference any key areas. And we've got a bit of focus with Telford and Wrekin at the next meeting. And the second one, and I know Kathy would want to say that, is this meeting also with includes in the title, we really do focus on the prevention angle as well as on the strategic side. And it's a real focus. And again, big thank you to our Directors of Public Health from both local authorities who've really helped us develop that prevention framework.
Any comments or questions? Note the report. Roger, I missed the audit committee. My apologies. Anything for the audit?
No, I think one point to really add is that communication has now begun to happen with staff in Stoke-on-Trent, ICB, around audit arrangements going forward, and more will be updated in due course.
And we'll have a conversation in the part 2 about some of the steps we need to take to get there. People, Culture and Inclusion Committee, Stacey.
There was just one recommendation, Chair, for the board. The committee asked if possible, to schedule a presentation around on the partnership between Telford College and Quay that we heard at the People Committee. I think it's a really positive story to share.
Yeah, definitely need to do that. That's something we'll build into our plan for next sort of couple of board meetings.
Thank you.
Great, thank you. So apart from that, note the report. Thank you. Remuneration Committee, Trevor. You note the Remuneration Committee reports. Thank you. And then the Transition Committee. And again, we had the first meeting yesterday of the Joint Transition Committee of both Shropshire, Telford, Wrekin, and Staffordshire and Stoke-on-Trent. The first time when the two ICBs actually met together in a formal committee as a committee in common. It was a useful meeting. Lots happening at real pace. I think that's the thing, the key message I was going to give to ICB colleagues, and linked to some of the conversations we had through Simon's report earlier on about the pace of change for colleagues across the ICB. And I think it's about making sure we're responding to those within a nationally set timescale, but doing that with transparency and compassion. But that's absolutely crucial and aligns with our values as an ICS. That's all I wish to say. And there's anything else that we need to do apart from just to note that the joint approach to transition. They're all of the committee reports. Any reflections on the meeting? Any issues that people want to flag in terms of how the meeting's been conducted, or the papers, or the approach? Again, thank you to colleagues from Shropshire for allowing us to meet here. It's appreciated. Any other business? It says that the next meeting's on the 28th of January. It may not be. That we obviously are needing to consider, subject to conversations later, the approach that we wish to take in relation to meeting in common with Staffordshire and Stoke-on-Trent. So that may be a different date that we need to look at. And Deborah, this is your last meeting. I know I've said this is your last meeting 3 times now, but this, I think, is your last meeting. And again, I've only had the privilege of working with you since July, but I know that colleagues would want me to take this opportunity to thank you for your not only your service as a clinician within Shropshire as a general practitioner, but also your commitment to system leadership. And that's been very clearly demonstrated around this table, but in other spaces and places as well. So all the best for the future, whatever that is. But thank you for all that you've done to support the improvement of healthcare for the population of Shropshire, Telford and Wrekin.
Just to follow on a similar theme, so would echo that, Deborah, in terms of that and the work that you've done previously. It's also going to be, it's Alison and Nigel's final meetings as well. So also would want to echo that and recognise that work and commitment that both Alison and Nigel, in terms of supporting the board, supporting the local population through a number of iterations and changes. And I know that will continue over the coming months as well. But in terms of from the board's perspective, would want to say thank you for that and say thank you for that.
Thank you. Thank you very much. And thank you very much, everybody. Members of the board and partners, if you wish, there is a closed session which will start in about 7 minutes. And so that can't be released yet. But members of the public, thank you very much for attendance.